Audio good? Oh, nice. Great. So I think we're going to go ahead and get started, everyone. We're a little bit, starting a little bit behind, but I wanted you guys to get a little bit of a break. We'll have plenty of time to cover a lot of stuff. And for this session, I hope you can feel free to just, raise your hand, interrupt. I know that when everyone was in the room, maybe it's harder to ask lots of questions, but the goal here is for you to ask questions. And also, don't forget, I think we have either it's an hour or an hour and a half this afternoon where we'll have a panel of us that are just here to answer questions. So feel free to ask questions now. Also, feel free to write them down, hold them off until a little bit later on. So, yeah, it looks like for the physician panel, we have an hour and 15 minutes this afternoon just for questions. But this session is all around idiopathic multicenter Castleman disease. We're going to talk more about the subtypes of iMCD. We're going to talk about symptoms and treatments, how you can manage it. So let's click ahead one more time. So just at a really high level, let's talk about what iMCD is. I know we've spoken about this a bit already. Talk about the term idiopathic. That means we don't know what causes it. So this is the subtype of Castleman disease where it happens to us, but we don't know why. So as you heard from our research team, we're trying to figure it out. It isn't a virus. We really thought it was likely going to be a virus. It isn't a virus. It's not clearly caused by autoantibodies, although maybe they're playing a role. It's not super clearly being caused by an inherited genetic mutation. Again, though, they may be playing a role. So we've still got some work to do, but thus far, it is still idiopathic. Go back one slide. About 1,500 patients diagnosed per year in the United States. Similar prevalence between males and females. It affects individuals of all ages. So if we have children diagnosed before their first birthday, individuals diagnosed all the way into their 70s, which is very unusual for diseases. Diseases usually have a specific age range, but Castleman's affects individuals of all ages. It certainly is a life-threatening disease, but with the appropriate therapies, it can be controlled. Some patients in this room, I personally was diagnosed August 13th of this year will mark 14 years since I first got sick. And so many of us can have, really nice, long remissions, and we can do really well with this disease. There was a great question earlier about, well, what about all the subtypes of iMCD? And I didn't go into all the subtypes of iMCD because it gets even more complicated. But there are at least 3 subtypes of iMCD. And as we go through them, it'll become more clear why it's important to subtype iMCD further. So let's go to the next slide. One subtype many of you all might have heard of is the TAFRO subtype. It's an acronym for low platelets, which is also called thrombocytopenia, anasarca, which is a term for fluid all over your body, renal dysfunction, meaning your kidneys don't work, reticulin fibrosis, which is a change within your bone marrow, and then organomegaly, which means enlarged spleen and or liver. And so you need 4 of those features to have what's called TAFRO syndrome. Patients with TAFRO, I fall into that category. We tend to get the most sick the most quickly, but we also can get the most healthy. So we get really, really sick, and then we can get back to living healthy lives. That's more the TAFRO group. Then there's another group, which we call IPL, which stands for idiopathic plasmacytic lymphadenopathy. And now the reason that it's called IPL is this actually was a name given to it over 20 years ago. But IPL, these patients tend to have really high platelets instead of low platelets. They tend to have really high levels of antibodies, another term from their gamma globulins. They tend to have a more chronic illness where they don't get quite as sick as a TAFRO patient, but they don't get quite as healthy as a TAFRO patient can get. It's sort of more of like an ongoing chronic inflammatory state as opposed to TAFRO, which is really up and down. IPL is much more sort of progressive disease. And then NOS are those people who don't fall into either category, not otherwise specified. So we have people who they're not quite TAFRO, they're not quite IPL, and they sort of fall in between. Any questions? Has everyone in the room, like if you're in the room, you either have iMCD or you have a loved one with iMCD, maybe a show of hands, has anyone not been told by their doctor their subtype or not heard about these subtypes? Any show of hands? And it's okay. It's just interesting. It's good to know. So that means the majority, it seems like the majority have been told about these sort of subtypes. And one of the reasons why I wouldn't hold it against your doctor for not telling you about the subtypes is because right now we don't treat iMCD any differently based on one subtype or another. So it's not like, okay, if you're TAFRA, you need to get this drug, if you're IPL, you get this drug. So it's actually very reasonable that your doctor didn't mention to you the subtype, because the doctor may not know that there's necessarily subtypes. But the reason I think it's important, and the reason we as a team think it's important, is that the subtypes do tend to behave differently. So we can expect things from our disease based on the subtype that we have. So maybe I'll become more clear as we go forward in the slides. Any questions at this stage on subtypes? Yeah. You were told Castleman's. That's a great point. So for those that are on video, she said that when she was diagnosed, she was told you have Castleman's. She wasn't told she had iMCD or her subtype of iMCD. And as you've heard already, with all these subtypes, you treat the disease very differently depending on whether it's unicentric or oligocentric or multicentric, and then whether it's idiopathic. So these subtypes are really important because it really affects how to treat it. So we obviously want to move beyond that to really knowing this is the subtype. That's a great comment. Yeah, Gary?
Is there much overlap between iMCD, NOS, and oligocentric?
Yeah, it's a good question. There is more overlap between the NOS people that don't fall into TAFRO or IPL and more oligocentric. It is sort of this. It's a bit more of this sort of intermediate group. So yes, there is some overlap there. And I guess the other thing is that for those in the room, I mean, I'll actually go back one slide. Some of you may look at this and say, well, I'm not really sure which category I fall into, right? And so I think the easiest way to determine just sort of the quick and easy is if you remember your doctor's ever talking about your platelet counts as being low, then you're probably on the TAFRA side. If you ever hear your doctors talking about, oh my gosh, you got really high platelets, then you're probably on the IPL side. And if your doctor never talked about platelets, then you're probably NOS, because Castleman's patients with TAFRO get really low platelets, like critically low platelet counts, where you're at risk of serious problems. And people with IPL have really high platelets, where your doctors are definitely going to comment, wow, your platelet counts are really high. So that's sort of an easy-ish way to determine where you might fall. Yeah?
Sorry, I missed earlier when I had a blood draw. But I was told I have HHV8 negative. Is that
That's right.
a subtype? Is that?
Great question. So HHV8 negative is what you have to be in order to be called idiopathic. And so everyone in this room, if your doctor's ever said you have idiopathic multicentric Castleman's, that means that you are HHV8 negative, and it means you also don't have POEMS syndrome. POEMS being a cause of cancer in your plasma cells. So basically you needed to have that test done to be negative to be able to say that you could have iMCD. So all of these are HHV8 negative. It's a great question. Cool. Any other questions before we go to the next slide? All right, let's go to the next slide. A little bit more about TAFRO, and you can click through a little bit. It sort of spells out the different things again, so I don't think we need to go through it in much more detail. Let's keep clicking through. Cool, and keep clicking through. So yeah, this is, I don't know why we have circles over our faces. That's me on the left, and Gary, sorry to disclose, but that's Gary on the right. This is not a HIPAA violation. But yeah, so we tend to be the ones who are usually in the ICU, the TAFRA patients. And as you can see, Gary's on a ventilator in this, and Gary looks like $1 million these days. Round of applause for Gary. Woo-hoo! So, like I said, you can get really, really sick like me or Gary, and you can get really, really healthy with TAFRO. And then let's click ahead. And sort of the point of this slide, and sorry the resolution's not great, is to basically say that no matter what your subtype of iMCD is, it causes what's called a cytokine storm, where basically your immune system is doing all the bad stuff we were talking about this morning. And the term cytokine is a word we use to describe proteins that your immune system releases to cause problems. I mean, their intention is to kill bad things like viruses and fungi and bacteria, and to communicate with one another. They actually can cause a lot of harm along the way. So that cytokine storm happens regardless of whether it's TAFRO or IPL or NOS. All of the cases are HHV8 negative, so we don't know what causes it, but they all have this cytokine storm involved. The next slide.
Excuse me, Dave.
Oh, yeah, sure.
Sorry, with the cytokine storm, how do you know, like, is it a blood test? How do you... So with the cytokine storm, how do we know that's happening apart from we're really sick? Is there a blood test? What do we look for in the blood
Great
test
question.
to know that that's actually happening?
Great question. So you can actually measure cytokines in the blood, but most hospitals don't measure cytokines in the blood. It's hard to do. And so the easiest way to know that you're having a cytokine storm, if you have Castleman disease and your albumin levels start to go down and your C-reactive protein levels start to go up, so albumin down, CRP up, that's telling you that there's lots of inflammation, and that's likely due to these cytokines. And so it's sort of like that's the cheap and easy way to measure your cytokines, is because albumin and CRP are fairly easy tests. CRP up, albumin down, that's when I start to worry, at least for myself and for other patients. If you hear that one's off or the other's off, I don't really worry too much. When I hear albumin's down, CRP's up, now I start to worry, because that's telling you that there's inflammation happening, and it's likely due to these cytokines. Yeah, absolutely. And then the other thing is then you can actually measure cytokines. But cytokine levels are pretty unreliable in that they can change really rapidly. So your immune cells are putting out all these cytokines from one lymph node or some part of your body, and they can change hour to hour. And so it's hard to really rely too much on actual cytokine levels, but albumin and CRP are really reliable. Any other questions on this? Cool. All right, let's go to oh, yeah, perfect. You can actually stay on the slide for a second. So I don't know if anyone in this room has POEMS syndrome, and you don't need to necessarily raise your hand to volunteer it, but I did want to spend a little bit of time talking about POEMS. POEMS occurs when you have, so in your immune system, we all have heard about how our immune system makes antibodies. The way that our immune system makes antibodies is that B cells become what are called plasma cells, and those plasma cells make antibodies, which can be really good. They help you to fight COVID, or they help you to do whatever you need to protect yourself. Those same plasma cells, when they become cancerous, they can create something called multiple myeloma, or they can create something called POEMS syndrome. Multiple myeloma is much more common and much more well understood. Again, it's cancer of these plasma cells. But the rarer form is where those cancer cells cause POEMS syndrome. And I think it's important to mention, because people with POEMS syndrome can develop multicentric Castleman disease because of the POEMS syndrome. And so it's the rarest subtype of Castleman's. And I actually don't know if anyone in the room has it, but I want to at least recognize it. Great. So we have at least a couple people I'm seeing that are in the room. So I want to make sure we addressed POEMS, and there's probably also people online as well. So POEMS syndrome, form of multicentric Castleman disease, it's caused by a cancerous plasma cell population. Those plasma cells are producing a lot of the bad stuff that you see in idiopathic multicentric Castleman disease, all those cytokines. But in this case, we know it's because of these cancerous plasma cells. Let's go to the next slide. A little bit more about POEMS. So, and can click through here. So POEMS involves polyneuropathy, meaning your peripheral nerves can have loss of sensation, so that's sensory neuropathy, or can have loss of ability to move, which is motor neuropathy. Again, organomegaly, like you see in TAFRO, endocrinopathy, endocrine challenges, monoclonal protein, and skin changes. So the two things that I look for when I hear someone is diagnosed with multicentric Castleman disease, there's really three things that come to mind that I want to test to confirm that it's either idiopathic, HHV8 positive, or POEMS associated. The first is you want to do that HHV8 test at the lymph node and the blood. If it's negative, okay, it's not HHV8 positive MCD. The next thing is you want to rule out POEMS syndrome and make sure it is or isn't POEMS. And so if you look in the blood to see if there's what's called a monoclonal protein, you do something called an SPEP, and we can share all this information with you afterwards. But if you have an SPEP and you don't have issues with your nerves working, so you don't have either issues of sensation or issues with moving your muscles, then you definitely don't have POEMS syndrome. Patients with POEMS syndrome have elevated level of this, it's called an M spike in the blood. So that's a simple, easy, cheap test that everyone with Castleman should have done just to confirm you don't have an M spike. If you don't have an M spike and you don't have sensation issues or muscle issues, you definitely don't have Poem syndrome. But if you have both of those, then you should be concerned about Poem syndrome because you need to treat it differently than if your Castleman's is not caused by Poem syndrome. Yeah, question? It's a great question. Dr. Van Ree should have done it on everyone. So if you see Dr. Van Ree or you come to Penn, Penn or Little Rock almost certainly will do the SPEP, serum protein electrophoresis. There are other places that just won't do it because they're not as familiar that this is going to occur. But the other thing is that if you're responding well to your treatment for iMCD, then you probably don't have POEMS MCD. It's that if you're like not responding to the typical iMCD treatments, nothing seems to be working, then you might need to start wondering like, could I possibly have POEMS? Especially if you're having issues with like strength and sensation. Yeah. Yeah, it's a great question. So, and I can restate it for you for the virtual folks. So, will the M spike be there permanently, or would it go away if you get better? The answer is a little bit of both. So, yes, your M spike can come down with treatment, but there'll likely always be a little bit of a sign that you have that monoclonal population. So, it's a nice thing to measure to see if the treatment's working because it should come down with treatment. Any more questions? Great. These are all really good questions. Hopefully they're helpful for folks in the audience and listening online. Great. Let's go to the next slide. So let's talk about symptoms. And this is the part that I always say that we don't need to talk to you guys about because you already know all the symptoms. But, it affects the body head to toe. Patients, like myself, feel fatigued and can fevers and night sweats. Often the organs that seem to get affected the most are the liver, the kidneys, and the bone marrow. So you get lowered counts of red blood cells and platelets. Your liver is responsible for making albumin, so when those levels start dropping down, that's not good. Your kidneys are responsible for making urine, and so you'll start urinating less frequently, which means that you'll gain fluid. Because the fluid, if you take it in, it's got to either come out or it's going to stay in your body. So if your kidneys stop working, your fluid's going to stay in your body, and you're going to get very swollen. Then there's some lab tests that we see pretty consistently in Castleman's. Any questions about any of this stuff or anything, any symptoms or things that you have that aren't up here, or that questions about anything that we do have listed? There's one symptom that I don't think we actually have up here, but that we do talk about quite a bit within Castleman's or within our group is something called eruptive cherry hemangiomas. And so a cherry hemangioma, or what's often called senile hemangiomas, are blood moles, and they can appear on your skin. And they're called senile hemangiomas because it's very typical to get them as you get older. It's totally normal to get hemangiomas as you get older. What's abnormal is what we call eruptive cherry hemangiomatosis, which means that they erupt over the course of just a few weeks, where instead of getting maybe one a year over the course of your life, you get 20 or 30 in a week. And so that was actually that was my first symptom of Castleman disease, is I remember I was a healthy medical student. I was delivering babies in a hospital in Bethlehem, Pennsylvania. And I just started noticing these blood moles popping up all over my chest and my shoulders, and I had no idea what they were. But that was my first symptom. I got like 20 or 30 of them just popped up all over my body. And then within a few weeks, I was really sick. And what was interesting is it turned out that as I got treatments that would get me better, those hemangiomas would shrink away. They would be, sticking up maybe a quarter centimeter off the surface, and then I'd get treatment and they would shrink back down to be flat. And so actually still to this day, every morning when I wake up, I put my fingers on my hemangiomas and I see how they feel, and they're flat, and they've been flat for 10 years. But it's just sort of, for me, every time I've gotten sick, those hemangiomas grow. When I get healthy, they flatten out. Any questions on any of this stuff? Yeah. Mike's doing a great job getting these mics out there. We're getting his workout in today.
Thank you. Hi, David. Just one symptom that I feel should be there as well is joint pain.
Yes.
Yeah.
I'm glad you brought that up because it actually typically was not on the list of things, but because of you, because you're part of Accelerate, and because you all shared your records with us, we did learn that a large percentage of Castleman's patients do have really bad joint pain. And it's never been part of anything about Castleman's. That's just not been something that's been described. But I'll tell you, joint pain is one thing that came very clearly through the medical records. The other thing is GI problems. And so diarrhea, nausea, vomiting, that has never been considered part of Castleman's, but it is incredible. And I myself dealt with it when I was first sick. I mean, like 70, 80% of us, nearly all of us around diagnosis have horrible GI problems, which oftentimes sends our doctors down all kinds of other rabbit holes, thinking we have something completely different. Or to your point, maybe because of the joint pain, they're thinking about something completely different too. But it's important that we should know, and that's a great point, we actually should update these slides to get across those two really big findings, which is GI disturbances and joint pain are absolutely part of Castleman's. Great point, thank you. Anything else on people's minds?
There's one more question from a Zoom attendee,
Sure.
and they were asking, they were reading that there was some interesting cancer research about switching off certain T cells, and is that something that's being looked at?
Yeah, so in the world of cancer therapies or cancer immunotherapy, sometimes what you'll do is you'll try to basically supercharge and boost up T cells to kill your cancer. In Castleman's, we feel like we want to sort of disarm or quiet down those T cells, because the same T cells that are good at killing cancer are also really good at attacking our organs. And so we do learn a lot from the cancer world, but we haven't yet taken the approach of boosting up T cells. It's not a bad idea at all. I think it's something that we should look into. But thus far, we've been thinking about it from the other side. But I do think that there could be potential to boost up T cells to kill, maybe to kill your plasma cells, for example. But we just haven't done that yet. Oh yeah, question up there.
Wanted to find out, is there any link to osteoporosis with Castleman's? And second question is, do people notice weight gain? Is that the symptom of Sylvan or a symptom of Castleman's?
Great question. So osteoporosis, we looked at all of these, what are called comorbidities, which are diseases that you had before or during your Castleman's diagnosis. And not surprisingly, osteoporosis showed up as something that's often found in our Castleman's patients before their diagnosis of the Castleman's and also after diagnosis of the Castleman's, but it wasn't any higher than what we'd expect in the normal population. So basically to say osteoporosis is one of the most common conditions that we as humans encounter as we get older. It's possible there could be a slight increase due to some of the treatments that are given, so steroids will increase your risk of osteoporosis, but it didn't look like there was a really clear signal that like, oh my gosh, this is definitely linked. We think treatment could link them. And then the question around weight gain with siltuximab, it's a really interesting question. Many of us with Castleman's that are really sick before we get the Castleman's diagnosis, we spend months, maybe even years in a state where our immune system is basically destroying our bodies. And so the moment we start on siltuximab and start controlling the disease, we oftentimes start gaining weight because we get our appetite back because we're no longer a sick person. And so we gain weight because we're now no longer sick, we're healthy, and that's the reason. That seems to account for at least some of the weight gain, is just getting back to normal and getting back to just being healthy. And then in some patients, it does sound like there could even be some further weight gain, but it's hard to know whether it's just because like you're healthy again or if it's because maybe there's something related to the medication. I don't think that's been teased apart, but I can tell you, like for me, when I started feeling well again, I mean, all I wanted to do was eat food because, I'd spent so much time nauseous and, unhealthy and unwell. And then so let's do one more question, yeah.
Sorry. I'm wondering for Castleman patients, does the SED rate always stay elevated? I know it fluctuates, but is it always kind of on the higher side?
Great question. So sedimentation rate is another good marker of inflammation. I mentioned C-reactive protein earlier because C-reactive protein is a little bit more reliable and accurate. Sedimentation rate can go up and down for some different reasons. And women actually have a sedimentation rate that's twice as high as men at baseline. So for that reason, sometimes, I usually encourage people to focus more on C-reactive protein, because sometimes just basic physiology of being a female versus a male, you're just going to have a higher sed rate, and other things can factor into sedimentation rates. So I don't usually put as much weight into it as a C-reactive protein, but yes, it should go up when you're sicker, and it should come down when you're healthier. But there is some other biological variation that's hard to account for. Great. All right. Well, we're going to keep clicking through, and there'll be plenty more time for questions. So let's click to the next slide. So what we wanted to show here is start showing you some data from Accelerate. I should also just make this is a comment or a follow-up from Mike and Melanie's awesome talk this morning. Their goal for today was to sort of show you what's on the horizon. What are the things that are like we're doing right now, your samples are being used for, that we're working on. Obviously, what they didn't do was go through sort of the last 12 years worth of work. And actually, we as a group are closing in on 100 scientific publications from our work over the last, 12 years or so. We're up to like 95 or something like that right now. So I guess I just wanted to highlight that we were telling you the things that were like sort of almost there on, but of course there's this incredible body of work, as I mentioned, almost 100 scientific papers of things that are completed. I wanted to highlight that. So this is one of those things that's completed. It was a study we did using our Accelerate registry, and I really hope everyone in here is part of Accelerate. I would literally beg on my knees for you to join Accelerate if you haven't joined yet. It's so important to get all of your medical data so that we can learn and patterns between patients. So this is some data from Accelerate. I know it's probably a little hard to understand, but the left side is pointing out, the middle line is when people are diagnosed, and the red bars are for how long people are hospitalized on either side of their diagnosis. What you see is there's a lot of people that actually spent a lot of time hospitalized before they ever got their diagnosis. And then there's also a lot of people who are hospitalized after their diagnosis. And maybe not too surprisingly for those of you that are TAFRO patients in the room, the average TAFRO patient spends 2 months hospitalized in the 12 months around their diagnosis. So 2 out of 12, that's the average patient. And then you can see there's some people at the top, the overachievers up there, that are closing in on almost the whole year around the time of diagnosis hospitalized. And so the big takeaway here is TAFRO patients will spend weeks and weeks and weeks hospitalized around their diagnosis. NOS patients will spend less time hospitalized, but still very significant time in the hospital. And I should also mention that the reason we just have NOS, we don't have IPL, is in this particular study, we included NOS and IPL in the same group because at that stage, the sample size was a little too small to separate out further. So let's click to the next slide. And so again, you can see broken out between the TAFRO and NOSs. You can see a large portion are getting fluid removal, getting red blood cell transfusions, dialysis. Platelet transfusions are all in the TAFRO patients. This makes sense, right? Because TAFRs are the ones with low platelets, so the other patients don't need platelet transfusions. But a large proportion, 16.7% of patients on a ventilator with iMCD, that is a huge, huge proportion. This is, I don't have to tell you all this, but obviously this is, very, very serious. As you see, GI accounts 84% of patients within the 12 months around diagnosis had some GI disturbances. Again, this was not part of what we knew about Castleman disease, but it's because you all gave your records to Accelerate, we could pick up these trends. Let's see. Any comments or questions on any of this stuff before we go to the next slide? Cool, we'll click through the next slide. And so what you saw from the previous two slides is the TAFRO patients tend to be the ones that spend the most time in the hospital and have the most procedures, like being on a ventilator. What we learned also is that the TAFRO seems to be more time in the hospital, more procedures. The NOS patients tend to spend the most time unwell, meaning that they're not in the hospital, but they're feeling really unwell. Their blood tests are abnormal, they're feeling lousy. And so it's this case where the TAFROs get really, really sick, but they also get much better than the NOSs and the IPLs, which get pretty sick, but they never get really well. And I think that's a really important realization. So for those patients in the room that are not TAFRO patients, hopefully you feel some understanding from us that you are going through a really challenging road. You may not get as sick as one of us, the TAFRO patients, might get, but your road is really challenging. And sometimes it can be, a longer road. Next slide. And then this is looking at some of those comorbid conditions before and after. And you can see renal failure is by far the most common diagnosis after a Castleman's diagnosis. So that's kidney failure. Next slide. Great. So now we get onto treatments, which I think is probably why you guys are all here, and probably the most important reason that CDCN exists. Let's click forward. So we came up with these treatment guidelines a few years ago, and the number one takeaway from our treatment guidelines are that every patient with idiopathic multicenter Castleman disease should receive siltuximab first. Siltuximab is the only FDA-approved drug for idiopathic multicenter Castleman disease, and it's got really, really strong data from randomized controlled trials. It's got really good safety data, long-term data. We should all get siltuximab first. If we're really sick, so if you're on the far right side, you should definitely get it with steroids. So to be on the severe side, you need to be hospitalized and you need to be quite ill. So you should get steroids with your siltuximab. If you're on the non-severe side, which is maybe more like a mild, moderate presentation, maybe you should have steroids added, but maybe you can just get siltuximab alone. So either way, siltuximab should be first. In somewhere between 35 and 50% of patients that are treated with siltuximab, you're going to respond well to siltuximab, and you're not going to need to worry about doing anything else. Yankee's a great example of this, right? Get the drug, feel great, have the energy of an Energizer Bunny. That's she's the poster child for that, right? And then there's other patients where they're going to be really severe and they get IL-6 blockade, but it's not sufficient. It either is not enough or maybe it just doesn't work at all. And those patients, if you're severe and you're getting worse while you're severe on IL-6 blockade, you need chemotherapy. And I wish that you didn't, and I wish I didn't need chemotherapy, but I've seen in cases where doctors haven't been aggressive with chemotherapy and those patients have passed away because they waited too long. And so I'm very bullish, and our guidelines are very bullish, that if you're on IL-6 blockade and you're in the hospital and you're getting worse and it doesn't seem to be working, chemotherapy can be completely life-saving. I've gotten 4 massive rounds of chemotherapy. Each one of them I needed. Each one of them saved my life, and I'm so thankful for them. They got me back to the life that I had before. No one wants chemotherapy, but wow, can chemotherapy be amazing when it's needed. Then on the non-severe side, if siltuximab doesn't work, now you should be thinking about things like rituximab. You should be thinking about things like sirolimus, the drug that saved my life. Drugs like thalidomide, ruxolitinib. But what you'll notice is that I'm saying drugs like, because it's actually not that clear what is the next best drug to try after siltuximab. That's why we're doing the clinical trials we're doing. That's why we're collecting all this data through the registry. Siltuximab is clearly first, and then what to do next. If you're non-severe, you probably should try rituximab. If you're very severe, you should probably go into chemo. And then if those things aren't working, then that's where you're in the realm of sirolimus, ruxolitinib, thalidomide, and some of these others. But I think it's also important to point out this seeking expert advice. On either side, if you're getting siltuximab and that's not the right drug for you, that's where your doctor and you should really be thinking about getting to an expert to figure out what else could be done. Any questions on any of this stuff? Yeah. This is another poster child for siltuximab we're about to hear from.
Well, I'm not the poster child, but
You're the partner of the poster child.
I'm the loved one. So this guideline talks about cetuximab with or without steroids. Is it clear on? Is that preference based off of the patient pushing? So that was one of my questions coming here. Is she keeps getting steroids when she's given her her treatment?
Yep.
And I was always questioning, I don't know if I want her to get her steroids every single time. So is that something that the doctor's just looking at the guidelines and it says yes or no, or are you pushing for let's try it without it?
Yeah, good question. So when you get steroids with the infusion, that's not steroids like we're describing here. Steroids like we're describing here would be continuous steroids, daily pills. When you get it with your infusion, that's really to prevent a reaction. Anytime you get a monoclonal antibody like siltuximab or rituximab, you're at risk that you might have like an allergic reaction to it. So the steroids, which I'm sure some of us, I've had them too. So the steroids day of, I would recommend keeping them on because they're low enough to where they're not going to be affecting day to day, or they shouldn't really be affecting the disease are really sort of hormone levels, but they're good to prevent a reaction because we wouldn't want a reaction. But yes, I think these are all the right questions to ask. Yeah. And maybe while the mic's going over there, I'm just going to share a quick comment about in this particular case, and maybe you all can share more. But this is an example where I don't think you realized how much better you could get until you got siltuximab, right? It was like sort of, I remember we spent time talking and, weren't feeling well, got siltuximab, and all of a sudden you got your life back, which is, for me, it was like so exciting to see how you've improved. It's been just amazing. I love it. Yeah, please. If you feel comfortable.
Hello, I'm Frances. I am an adult patient, not a pediatric patient. I'm also not Yankee's daughter. No, so for those that don't know me, or maybe you saw me last year, I was in the middle of a flare, and actually a month after Summit, I ended up in the hospital in North Carolina, and I think I got there just in time to see my specialist, Dr. Voorhees, and he put me on siltuximab the following day after seeing him, because it was just a visit to get on siltuximab and to be under his care. And when I got there, my hemoglobin was at 4.4, so they put me on blood transfusion, CT scan, and then I just had a fever, and my organs started to get attacked basically every day. It was my kidneys, then my lungs, then my heart. So I was there at the right time, and I've been on siltuximab every 3 weeks since, and like I said, it's like a new life. Like, I'm feeling like Yankee, but maybe not as much. Oh, he wants me to mention that previously I was on rituximab and I wasn't seeing a specialist just because I'm stubborn, and David has been telling me to go see this specialist and to try siltuximab, but I was content with feeling better because it was better than pre-diagnosis. So I said I'll stick it out, and last year I made the decision to switch, and I just happened to go into a flare. So, I mean, stick with the guidelines is what I'm saying.
Oh, I love seeing you looking so good, Frances. Oh my gosh.
So I wasn't so lucky. I've actually been on Rituxan, siltuximab, and now I'm on tocilizumab. I've been on that for 3 years. But what I've noticed is, like, I don't actually have the greatest quality of life. I kind of feel like I have no energy, tired all the time. I kind of feel like with this particular treatment, it's just almost deteriorating a little bit. That's sad to say, but it's also kind of like, so some of us are gonna feel a lot of energy, but then some of us are not, is basically where I'm getting at. Just not to be the buzzkill, but not all, I look at Yankee and I'm like, man, I wish I had that energy. I wish I did. But yeah, with the Tosi, I will say, like, it keeps me in the remission period, but I still have all the others, the symptoms, the fatigue and the night sweats and all that stuff. So, like, for anybody that's trying these treatments, it's like, it is a process. You're going to go through it. Some of us are going to feel really, really great. Some of us are going to just manage, and that's where it's at.
That's right. It's a process, and it may be that there isn't a drug out there that can get you feeling. Well, there are some drugs that can make you feel like Yankee, but we don't recommend those drugs. Those are illicit drugs. But no, I think the key thing is that you're absolutely right. There are certainly people out there. I felt like I was one of them where there isn't a drug that's going to get you feeling 100%. But like I said, I felt like I was one of those, and then I found a drug that did get me to 100%. So it could be that drug is out there, it just hasn't been tried yet, or it could be that maybe there isn't a drug out there for you. But there might be one, right?
Hi, Dave. Two quick questions. One, if you're on siltuximab and you need ongoing steroid treatment, is that telling you the medication isn't working? And number two, has anybody tried siltuximab, didn't respond, tried other treatments, and eventually went back to siltuximab, and it became effective later?
Yeah, these are two really good questions. So usually we like to see someone go off steroids while they're on siltuximab, because that's sort of a test that, like, it's the siltuximab holding strong without the steroids helping. It's hard to know whether whether the lack of being able to work without steroids means the siltuximab is not working at all. But it's definitely a question, because we like to see people go off steroids, because being on steroids for a long time puts you at risk of a lot of problems like osteoporosis and other issues. Yes, we would like to see someone be able to go off steroids. Not being able to go off steroids, it's hard to know exactly what that means. And then in terms of your follow-up question, which was, I just lost my train of thought. What was it again? Oh, not responding, trying something else and then responding. Yeah, I've heard of a couple patients where it didn't seem to work early on, and then they went back on it, and it seemed to work later. I've also seen patients where it worked early and then it stopped working. So there are things like that can happen, but usually Castleman's is usually pretty consistent in that, like, if you treat Castleman's with the right drug for you, usually your Castleman's goes away, and then usually it stays away. Castleman's is a lot of lymphomas. You can give a drug, it can work really well for a month, and then it roars back. Castleman's is not typically like that. It's much more like if you hit the disease with the right drug, it gets better, and then it usually doesn't come back. Now, that's not the case for everyone. I'm looking at some people in the audience where you've hit it with the right drug, and then it's come back. So not the case for everyone, but typically Castleman's seems to be pretty consistent. I think we'll do one question, and we'll keep rolling through.
One question from our Zoom attendees in keeping with the siltuximab theme. With regards to after they start siltuximab, that they were diagnosed with iMCD tafro, producing a lot of ascites, what's the average for how long it takes to stop producing that ascites after the first treatment of siltuximab if it's working?
Yeah, this is a great question. So ascites tends to be one of the last, so ascites is fluid in your belly. It tends to be one of the last symptoms to improve after you're getting better. And so sometimes we'll have patients where they get siltuximab, they start doing better, their blood work's going to be one of the first things that's going to change. You see the blood work improving, albumin's improving, hemoglobin's improving, but the fluid is just, persistent. And some doctors and patients will get really frustrated, and they'll say, I don't think it's working. Look how big my belly is. But I always say, just be patient. The fluid is the last thing to come off. So don't let the fluid sort of concern you that it's not working. Lab tests are the best way to know whether siltuximab is working. Your albumin should get better, your hemoglobin should get better, your platelets should improve, all that such stuff should change. And then I think I know that there's probably some more questions. Let's keep clicking through this because we might have some more time for questions. I don't want to hold you guys up with lunch. And then also there'll be a whole hour, 15 minutes for questions this afternoon. So let's click to the next slide. And by the way, those treatment guidelines are published. They're freely available. Anyone can access them. We can give them to you and give them to your doctors. If anyone has Castleman's or they're treating a patient with Castleman's, they have to follow or at least know about the guidelines. All right, let's click through a couple of times. Basically just showing how IL-6 blockers like siltuximab work. Tocilizumab works similarly to siltuximab. It's much more widely available around the world outside the U.S. for Castleman's. As I mentioned earlier, rituximab, sirolimus, chemotherapy, and steroids are some other medications that are also often used. Let's click to the next slide. So we used Accelerate data to look to see how various treatments work for Castleman disease. And let's see, siltuximab is the red bar, and tocilizumab is the gold bar. And so this is sometimes hard to follow, but it's a survival curve where basically you see that the higher, the better. Basically the red and the gold, as you see, have the two highest levels of responses. So that's years without relapse. Versus the lowest would be corticosteroids. So one way to read that is that within 1 year, 3/4 of people treated with steroids are going to relapse or have progression of disease, whereas within 1 year, less than 1/4 of patients on siltuximab will have relapse. So it's just pointing out the fact that siltuximab has the best performance in terms of responding and also duration of response. Next slide. This is a table form. This is also published online in a journal called Blood Advances. Happy to share this with anyone, but it's basically comparing all the different treatment approaches for iMCD. And the second column is maybe the one that's most of note, and that's the response rate. And so you can see that siltuximab has about a 53% response rate versus you can see steroids, it's like a 2% response rate. And then you can compare it to others. And sometimes chemotherapy is needed. You can see chemotherapy has a 45% response rate. Sometimes you got to go to chemo, right? But we want to avoid chemo as long as we can, but sometimes you just have to do it. Next slide. And then I just wanted to show a picture of Carl. Carl was the very first patient ever dosed with siltuximab. He's at well over 300 doses that he's got on the drug, and I just love thinking about the fact that since 2005, or I think maybe even before then. Next slide. And then treatment for POEMs should really be directed at the POEMs, so it should be focused on those plasma cells that can cause problems. And then click through. So if it's localized, like you have a single hot area with these bad plasma cells, you can use radiation, but oftentimes you're going to need chemotherapy, and you may need a stem cell transplant. Next slide. All right, so let's talk about living with Castleman's. Let's click again. So yes, we should expect a very good outcome. And the reason we should expect a very good outcome is because if we go to the experts, the best doctors who know how to treat this, if we utilize the right treatments, if we're involved in research, and if we support the work that we're doing on the CDCN, we should all be really hopeful about the future. And this is not what I would have ever put on a slide 12 years ago, but I think we have a lot to be hopeful for right now. Let's click again. So the question is, how do treatments affect, your quality of life? How does having Castleman's affect your quality of life? Side effects, anxiety, questions about your family and pregnancy. There's a lot of questions. These are some of the more common ones that we get, and we'll try to go through these more quickly, or in the next 5 minutes or so. Next slide. So side effects of treatment, oftentimes weight gain. Steroids has a lot of side effects. Rituximab, the thing that you should be thinking about the most if you're on rituximab is the strength of your immune system to battle infections. So COVID, for example, is particularly hard to overcome if you're on rituximab. Let's see, go to the next slide. For IL-6 blockers like siltuximab, we mentioned earlier infusion reactions. That's why steroids are needed at the time of the infusion. Or risks. You can have low platelets as a result of your treatment. Chemotherapy, I think we all know the side effects that come with chemo, lose your hair, really low immune cell counts. Next slide. And so then these are some things that you can do. So the first thing you should do is to locate a doctor with experience with treating Castleman's. We can help you with that. Reach out to us, reach out to Madison. We can help you. Second is learn about your disease and your subtype. You guys are here, you're doing all the right stuff. Third is to monitor your symptoms and treatment. Track those things. I have a couple slides in a little bit to go through how I do tracking. But so first off, keep track of the symptoms that you presented with. And so I mentioned earlier, Castleman's is consistent. What that means is that when we relapse, we tend to relapse with the exact same symptoms that we initially presented with. And so sometimes with Castleman's, we hear about someone like Gary who was in the ICU. We hear his story and we say, oh my gosh, I have iMCD. Is the next time I relapse, am I going to be like Gary? It's possible that you're going to be sick like that, but it's also more likely that you're going to present the same way that you have in the past. And so whatever those symptoms were, whatever those blood tests that were abnormal, they'll likely show up again if you relapse. And so that means you know what to look for. Okay, I know last time I was sick, I gained a bunch of fluid. I know I had these hemangiomas. I know I had a low albumin level. Those are the things you should be looking for. What you had last time can tell you what you should look out for next time. Next slide. And then I wanted to point out IL-6 levels. So interleukin-6 is the one cytokine that siltuximab blocks. And amazingly, between 1/3 and half of patients get better when you block that one cytokine. There are literally hundreds of cytokines. You block that one, the whole disease melts away. But importantly, a lot of doctors will want to keep measuring IL-6 levels to determine whether siltuximab is working or not. Unfortunately, the moment you get siltuximab, your IL-6 levels that are measured by the test are going to go through the roof. And it's not actually that you have high IL-6. It's that siltuximab is binding to IL-6, and the test is detecting both of them and thinking that you have really high levels of IL-6. So I'll get calls from doctors that are saying, my patient is relapsing. I need to take them, give them chemo or give them a transplant. And I'll say, well, wait a minute, tell me, why do you think they're relapsing? And they'll say, well, they're doing great, but their IL-6 levels are really high. And I'll say, no, don't do anything. That's totally expected. IL-6 levels should go up. If your IL-6 levels don't go up after siltuximab, there's something crazy happening. So don't pay attention to IL-6 levels for at least 1 year, maybe even 2 years after your last dose of siltuximab. Because I've heard from a lot of doctors and patients, and I don't know how many I've missed, that have actually wanted to change care because of an IL-6 blood test. don't pay attention to it if you're on siltuximab or toci. Same thing with tocilizumab, yes. You should also not pay attention to it. It's not as extreme. The levels go way higher with siltuximab than they do with toci, but they still go up on toci. Next slide. So I think it's important to do all the things, whether you're a patient or you're a loved one of a patient, that you know are good things for your health with Castleman's. There's no particular diet of removing this or adding that we know of that's any better than anything else, but we do know that taking care of yourself, we all know what eating well looks like. We all know what exercising looks like. We all know we shouldn't be smoking and drinking excessively. Like, we know that sort of stuff. You should do that if you have Castleman's. You should also do that if you don't have Castleman's. But yes, we all know what we should be doing. And I'm not aware of any special diets. There may be ways to do it, but we know that being healthy is the way to go. Next slide. And then I talked earlier about my Whoop. I love my Whoop. I'm going to share another story about my Whoop. So I got it a couple years ago, and the picture on the left is my result from January 5th, about a year and a half ago. So you get a score from 1 to 100 every day when you wake up. It tells you like your general state of health. And I woke up and it gave me a 1%, which is really bad. You want to be closer to 100. 1% means that your vital signs are off. So your heart rate's elevated, the time between beats of your heart is off, the respiratory rate's off, your temperature, all these things are off. That's what gets you to a 1 versus a 100. It's, what do your vital signs look like? And I didn't really sleep that well. Looks like I got, 6 hours and 47 minutes of sleep, but I didn't feel that unhealthy. I just, got this 1%. So I called my doctor that day and I was like, I kind of feel under the weather. I just got this 1% thing on this Whoop. And he was like, what's a Whoop? And so it's this thing. So I went in and he was like, let's evaluate you. So he said, let's do a chest x-ray. It turned out I had a really bad right lower lobe pneumonia. I had a really bad pneumonia that likely would have hospitalized me in the next few days. But because of my 1% score on Whoop, it led me to see my doctor. I got on antibiotics and I was fine. And so for me, I just love that there's this constant monitor. We all think about blood tests and we can go get our CRP levels and our albumin, and you're probably like me. My doctors never run the test as much as I want them to. I always want to be, checking my stuff, but this is a way to indirectly measure, what's your general state of health. I've never worn this before a Castleman's relapse because thankfully I haven't had a relapse in 10.5 years. But yes, I do know that every time I've gotten sick, and with my COVID, my Whoop score went down. And this is just, for me, it's peace of mind. Then now that I have COVID, I can see how's my Whoop score today versus yesterday. And okay, it's gotten better, so maybe I'm getting better. Anyway, so I have no connection to Whoop other than it saved my life here, I think, and I love it. All right, next slide. And then here you can see this is actually the last few days where you can see my respiratory rate went up the day that I started having symptoms, and then it's come back down. So it's just nice to be able to see things get better. Next slide. All right, so track those lab values. You mentioned earlier that certain lab values that are abnormal when you present, they're going to be abnormal again if you relapse. So you should be on the lookout for those things. Next one. Click a couple more times. These are all the key things you should be looking for. I always think when you think Castleman's, you should be thinking about what's your hemoglobin level, what's your albumin level, your platelet count, and your CRP. And if you have a track of those 4 things, and if any one of them goes abnormal, that's probably okay. But if 2 of them, or 3 or 4, then you should be concerned. All right, next slide. Having a positive attitude, I think, is so important. I think that a diagnosis like Castleman's can be so frightening. I completely get it, but I think we also have a lot of reasons to be hopeful. Next slide. We talked about this. Next slide. So all the stuff that we said that'll make you healthy is good for Castleman's. Next slide. And then seeking support. I talked about earlier how important loved ones are. You guys are our anchors. You're our support systems. You're amazing. Next slide. And then, the future is bright. And I think it's bright because of you all, because of all of the samples you've donated, because of all the data you donated, because of the research that you've enabled. You're creating a future for yourself that you wouldn't necessarily have had if you hadn't been a part of this effort. And we collectively are creating futures for all of us. Next slide. I think that I'll go through these really quick. Let's go again. We are really interested in the effects of Castleman's in pregnancy. I'm very lucky. I've got a 5-year-old daughter and a 2-year-old son. When I was going through all this, I never thought I'd live long enough to have children, and I certainly never imagined that I'd have such a special family. But we are thinking a lot about both males and females, the effect of having Castleman disease and your ability to reproduce. There's a lot of questions we get about, can I be on siltuximab and be pregnant? And there's a lot that we don't know, and we really want to learn more. And so these are really tough questions to think about and to wrestle with. But some of the stuff isn't in your medical record. You aren't necessarily sharing with your doctor some of this stuff. And so click to the next slide. We're going to be, at some point soon, putting together a survey around this. So males and females, whether you've become pregnant or whether you've tried to get someone pregnant and you have Castleman's or you're on a medication, and to better understand how this can affect us. Because I think we all should know, what's our ability moving forward to be able to have children. The second is around if you've ever stopped Castleman's. We're really interested in understanding, stop Castleman's treatment. We all want to stop Castleman's. So we'd love to know, some patients have stopped Castleman's treatment, have gone on to relapse, and we want to better understand that because we're seeing that happening more and more often. The doctor's saying, hey, let's give you a break from treatment, and we want to make sure that we understand that better. So either way, if you've ever been pregnant or wanted to become pregnant or wanted to have a family with someone, and you have Castleman's, let us know. We want to learn more about your experience, and same thing with stopping therapies. Let's go to the next slide. These are just some recent papers. Again, we haven't gone through the things we have discovered. We spent a lot of time talking today about things that we're working on. But, of course, we've discovered new treatment approaches like the drug that's saving my life, sirolimus, like ruxolitinib, that's saving Kyla's life, and others that are in this, other patients in this room. Next slide. This is a little bit more about mTOR. Next slide. Click again. This is about ruxolitinib, which is an exciting approach that we're getting ready to launch a clinical trial around. Next slide. Click again. Here's Kyla in the White House doing the Castleman's flex. Kyla was the first patient. Yes, let's cheer for Kyla. Because we're not going to have time for the video, right? We'd have to go over. There's a great video about Kyla. It's 5 minutes long. You guys want to watch Kyla's video? All right, cool. All right, so then I won't tell you any more about Kyla. You got to hear it from the video. All right, let's go to the next slide. I think this is the video on the next slide. Cool. And this is the last part of the talk. So once we get through this, we'll go right to lunch.
Imagine your daughter's being rushed to the ER without having any idea of what's wrong.
Suddenly we're taking our little girl downtown to a children's hospital and we're not really sure why yet.
Even worse, no medication is helping and you have no more treatment options.
All right, well, we know what it is, we know what can help treat it, but nothing's getting better.
But what if the drug that could save your daughter's life was sitting at your local pharmacy all along? This is Kyla's story.
I was 14, 15 years old, doing normal stuff like going to amusement parks and stuff, like hanging out with my friends, and I just did not feel good whatsoever.
She wasn't feeling good. Her stomach was hurting her. She was vomiting a lot. She was really tired.
They called and said, you need to take her to the ER right now. They did a number of scans, they did MRIs, they did the CT.
It was stressful to be in the realm of unknown, and watching your daughter suffer in the process.
Eventually, Kyla was diagnosed with a rare condition called idiopathic multicentric Castleman disease.
Castleman's is a rare inflammatory disorder where your immune system attacks and shuts down your vital organs for an unknown cause. It affects individuals of all ages and it can be deadly for many of us.
Kyla was the first patient with this version of the disease at Lurie's. They hadn't seen idiopathic multicentric Castleman disease before.
It was about 2 months between Kyla's initial onset of symptoms and her finally getting the diagnosis. And someone like Kyla that gets so sick with her Castleman's, that could actually be too long for some patients to even be able to survive that long. So we are so thankful that she was able to be diagnosed within 2 months, but this is why we've got so much more work to be done to improve the time to diagnosis so that people like Kyla can make it to their diagnosis so they can make it to getting the right treatment.
You know, she was a petite girl going into this, and then watching her kind of almost waste away to just bones. Even her kneecaps were exposed. She could slide her bracelets all the way up her arm. You know, that's how skinny she was.
One of the most startling visual aspects of this was the amount of fluid she was retaining. I mean, her belly looked like she was 9 months pregnant.
Kyla's parents reached out to us in September 2019. Kyla at the time was hospitalized in the ICU with all of her organs shutting down, and her doctors didn't know what to try next. And so I got connected to Kyla's doctors and began sharing with them about our treatment guidelines, how we go about treating Castleman disease, all of the newest research that we had to hopefully get a treatment that could work for Kyla.
One of us was by her bedside the whole time. We did not sleep separately. We were both in the room with her, whether on the couch or in the chair. That's where we slept for 9.5 months out of the year. We were her advocates. We did push for more answers. We spoke up when we noticed something wasn't right because we know her the best. We're her parents.
It was really hard for me to stay positive just because I was trying like so many different things and they just weren't working for me.
All right, well, we know what it is, we know what can help treat it, but nothing's getting better.
So they tried IL-6 blockade for Kyla, which is the only FDA-approved treatment for Castleman's, and unfortunately that didn't work for her. So they quickly moved on to a drug called sirolimus, a drug that our group identified in advance for Castleman's. Even sirolimus didn't work for Kyla, and so then we were into the realm of chemotherapy. And so chemotherapy was given to Kyla in the hope that that could get her into remission.
Just like hearing that you're gonna have to go through chemotherapy is scary because you see all like the horror stories about it and like horrible side effects, like losing my hair, which was a big change because I'm a girl, so I love my hair and I love doing it and everything, so it was a big change.
At numerous points, she had 2 tubes coming out of her that was just draining fluid.
She drained 7.5 gallons of fluid from her lungs. She definitely went through a lot. She is essence of a warrior.
So at a certain point where her doctors were really unsure if she was going to make it, her doctor reached out to me and said, is there anything even early stage experimental that might be able to work? And I said, well, we just made this discovery a couple weeks before in the lab that we think something called a JAK inhibitor, ruxolitinib, can maybe be effective for Castleman's. And it was literally just a couple weeks earlier that a PhD student in my lab had run the experiments that made us feel that this maybe could be a viable option. But they didn't have any other options for Kyla, so her doctor decided to try out ruxolitinib as the first time ever with Castleman disease.
I remember the date. It's July 31st of 2020. It's the first day she started that drug.
Yeah.
I was just excited when we got to go home and we stayed home. Yeah. I don't know about you, but we always bounce back and forth. We were home maybe for a couple days, maybe even 24 hours, and we were back in the hospital. So this time we went home and we stayed.
Ruxolitinib was first approved for a disease called myelofibrosis. It's a cancer that can occur in individuals, but now it's been repurposed for a couple other cancers and also immune-related disorders.
Ruxolitinib for Castleman disease is a great example of drug repurposing. It's also a fantastic example of how using a drug off-label for one patient can actually unlock its use for other patients. So drug repurposing is very special when you compare it to novel drug development because these drugs are available at the pharmacy for patients to have access to through off-label prescribing. So in this case, Kyla got access to the drug off-label, but that means that other patients can also access to that drug if we know it's effective for them. So Evercure is trying to leverage that initial use to increase the awareness of that as a treatment option for other patients so clinicians know to consider it as an option for their patients.
We are so excited that Kyla has been in remission for 4 years on this repurposed drug. Now, in the next 8 to 12 months, we will be launching a clinical trial to be able to reach more patients like Kyla.
One of the things that most impressed me with Kyla in and out of the hospital for basically 9 months over the course of a year, just how positive she remained. The nurses would come in and say, hey, we have to do this, we have to do that. All right, we got to poke you again. Okay, here's my arm. I mean, she was just always positive.
Definitely like having that support around, like family-wise, but then also like all the healthcare workers that were surrounded. It really helped keep me positive. Well, since like I was in the hospital for so long and was surrounded by like all my nurses, I decided that I want to go into nursing myself and like help other kids like my nurses helped me because I feel like it would be special because I have a patient's point of view.
Wow. Kyla, Sarah, you guys are just amazing. I'm got full goosebumps right now. Well, I'm so happy to see Kyla doing so well, and I see a lot of waterworks in the audience. We've come a long way, and I love seeing progress for patients like Kyla. We are going to be opening up a clinical trial of ruxolitinib for patients who don't respond to IL-6 blockade. We're hoping to open that trial within the next 6 to 9 months or so. So that drug, could be available here at Penn, also in Little Rock, Arkansas, for other patients where IL-6 blockade isn't working for them, but where they need another option. So I know that was a lot of emotion to bring right into the lunch break. But Kyla is here with us today. She's doing so well, and I'm just excited to spend the rest of the day with everyone.